السلام عليكم، مساء الخير. معكم خديجة العلي من دفعة 2015. إن شاء الله اليوم راح نراجع على السريع Respiratory System للاستعداد لاختبار البروجرس. نبدأ ب Restrictive Lung Diseases which are characterized by reduced lung expansion. It is either extrapulmonary or pulmonary. For extrapulmonary, it is caused by neuromuscular diseases or chest wall abnormalities. And for pulmonary, it is interstitial. For obstructive lung diseases, we have asthma, bronchiectasis, and COPD, including emphysema and chronic bronchitis. To differentiate between obstructive and restrictive lung diseases, we perform spirometry to measure the forced expiratory volume in 1 second and forced vital capacity ratio. In restrictive lung diseases, it will be either normal or increased. In obstructive lung diseases, it is reduced to less than 0.7. Asthma is reversible obstructive lung disease, which is characterized by hyperreactive and hyperresponsive airways that lead to bronchoconstriction. There are two subtypes: extrinsic asthma, which is mediated by type 1 hypersensitivity reaction. It begins usually in childhood in patients with a family history of allergies. Most common allergens include pollens, mold, and dust mites. Intrinsic asthma is due to non-allergic causes like cold temperature, exercise, and medications like aspirin. Unlike COPD, the process in asthma is reversible, so patients in between the attacks are relatively normal. A patient will present with sudden onset dyspnea, wheezing, and tachypnea, sometimes with chest pain. For diagnosis, we perform methacholine challenge test, which is inhalation of cholinergic agonist. When we perform it in asthmatic patients, this will precipitate a bronchoconstriction at lower doses compared to normal patients. The management will be by avoiding the precipitating factors, and for medications, we will give the patient beta-2 agonists and corticosteroids. Emphysema is abnormal and permanent airway enlargement distal to the terminal bronchiole, accompanied by progressive destruction of alveolar walls and surrounding interstitium. This results in loss of elastic recoil and air trapping. It is usually caused by either increase in elastase enzyme or deficiency in alpha-1 antitrypsin production. There are two major causes of emphysema, which are smoking and hereditary alpha-1 antitrypsin deficiency, which is autosomal dominant disease. The patient presentation will be chronic dyspnea that is worsened by respiratory tract infection or air pollutants. Also, the patient is described as pink buffer. راح أحط الصورة اللي تشرح البينك بفر إن شاء الله. For treatment, smoking cessation is most important. Also, supplemental oxygen in severe hypoxemia, inhaled bronchodilators like beta-2 agonist, also corticosteroids. Chronic bronchitis is defined as a productive cough occurring for at least 3 months per year over at least 2 consecutive years. It is characterized by excessive mucus production in the airways. Smoking causes proliferation and hypertrophy of bronchial mucus glands. It also damages the cilia lining the bronchial lumen, which impeding mucus clearance. This will lead to airways inflammation. The presentation, the patient will be described as bloater and with productive cough. راح أحط صورة للبلوتر والpink buffer. Also, for diagnosis, we will find increase in RAID index, which is the ratio of a bronchial mucus gland depth to the total thickness of the bronchial wall. For diagnosis, there will be a reduction in FEV1 and FVC ratio. Arterial blood gas analysis will show decrease in oxygen partial pressure and increase in carbon dioxide partial pressure. For the treatment, now moving to pneumothorax, which is accumulation of air within the pleural space. The patient usually present with dyspnea and unilateral chest pain. On physical examination, there will be decreased or absent tactile fremitus, hyperresonance, and diminished breath sounds on the affected side. It is classified as primary and secondary spontaneous pneumothorax, traumatic pneumothorax, and tension pneumothorax. Primary pneumothorax is due to rupture of apical blebs or cysts within the lung, with no significant history of lung diseases. For secondary spontaneous pneumothorax, it is also due to rupture of apical blebs, which develops secondary to lung diseases or due to mechanical ventilation with excess pressures. Traumatic pneumothorax is caused by blunt trauma such as rib fracture or penetrating trauma like gunshot. Tension pneumothorax might develop from any the etiologies that I mentioned. The air enters the pleural space with each inspiration but cannot exit, so the air will be trapped in the pleural space rapidly, which put the patient at high risk of developing respiratory failure and circulatory shock. It is detected on physical examination and chest X-ray. There will be contralateral tracheal deviation. The air pushes the mediastinum contents to the other side. Treatment of asymptomatic pneumothorax patients will be by supplemental oxygen, and for those who are symptomatic with severe pneumothorax, we perform thoracentesis or tube thoracostomy. For patients with recurrent pneumothorax, we perform pleurodesis, which is done by chemical or mechanical irritation to seal both pleurae together. هذه بعض المواضيع اللي تتكرر في البروجرس. للأسف الوقت ما يسعف إن احنا نغطيها بالسناب. كتاب الفيرست ايد اورجان سيستم كتاب جدا جميل، يختصر الأمراض ويعطيكم الشيء المهم منها. شكرا لكم، وإن شاء الله فاتكم الدرجات الزينة في الاختبار.